Good morning, everybody, and welcome to our second day of the late summer school of Ultrasound in Graz. I hope you all slept well and are refreshed for our second day. First of all, I would please could you come punctually tomorrow? So we'll start at 9 o'clock. We just don't want our lecturers to wait. Okay, so one point more. Yesterday, this was found in the second row. That's yours, okay. Perfect. Okay. I'm particularly happy to welcome our partner universities today who are watching us via live stream. You can see them here. Well, there are 7 this year, so a lot of. We've got Innsbruck and Zürich, Mannheim and Heidelberg. Also the Mannheimers and Heidelbergers. There are 3 and 3, 6 tutors of them here in this event. And Aachen, Bonn, Hamburg, and Berlin. So I hope they are watching right now and enjoying our summer school. I have the honor of introducing you to our first lecturer today. It's Dr. Paul Puchwein from Austria, from Graz. He is going to familiarize us with the eFast protocol used in the examination of the traumatized patient. He's a specialist in the fields of orthopaedics and traumatology and is the head of the traumatology section from the Medical University of Graz. Besides being an approved risk manager, he is also part of the air emergency team, and he was certified by DGUM, the German Association of Ultrasound in Medicine, for the use of ultrasound in emergency situations. So exactly what we want to learn from him today. I'd say, let's enjoy learning from an expert. Please welcome Dr. Puchwein.
So good morning. Is this the right position here to stand? I hope so. Okay. Thank you very much for your introduction. And here? Okay. So well, I've here the presentation. Thank you very much for the invitation. Yes, well, have just finished my night shift, so I look perhaps a little bit disheveled. But let's start with the topic, the traumatized patient, and what's the role of eFast in this situation. So these are some pictures taken from the emergency room. Last years we had much more stabbing and gunshot wounds than early years, so we have to learn to deal with such injuries, and eFast plays an important role even in preclinical situation as well as in emergency room situation. And I will give you a short, perhaps some short introductions about what we do in the emergency room and what we do in the preclinical settings. So we have several things to deal with in emergency patients, in traumatized patients, and one of the main issues is the so-called NCTH problem. It's the non-compressible torso hemorrhage, and this is a problem we cannot really deal with in a preclinical setting and even in shock room setting if we don't start with an laparotomy or thoracotomy. So what's the problem with this non-compressible torso hemorrhages? For example, if we have injuries to the limbs, we can use tourniquets, we can use other devices to reduce the bleeding. We can use vacuum splints, mattresses to reduce bleedings in fractures of the limbs. And we can use pelvic splints to reduce bleeding in complex pelvic injuries, open book fractures, C-type fractures, and so on. But yet we do not have really good answer for these NCTHs. Another thing is we started now several years ago with the emergency thoracotomy in a preclinical setting. Here's a picture taken from our training at the Anatomical Institute. And perhaps we will find some answers in future if we talk about the use of rebore, this is a balloon you can inflate in the aorta to reduce arterial bleeding. You can use this junctional tourniquets for blast injuries and so on, and this injection gun to fill the abdomen with polyurethane foam to reduce perhaps bleeding in hollow organ injuries. But this is not still now routine. So we have to find these patients with the NCTH. We have to sort out them very quickly to know what patient needs a surgeon immediately. So there's no point about this. NCTH still requires immediately surgical treatment, so-called damage control surgery. We know time is life in these patients. We should avoid futile time-consuming diagnostics. So if you perhaps have a patient in the emergency room with free fluid in the abdomen, stop with CT scans or anything. Go directly to the operating theater and stop the bleeding. So this is the message you have to give the other surgeons or the other team members in the emergency room when you do this eFast scan. So let me tell you something about the history of the FAST. FAST stands for Focused Assessment with Sonography in Trauma, and FAST is now one of the most important point-of-care diagnostic tools in the emergency room. And it focused initially on free abdominal fluid, and this is one thing you have to consider. It's not a normal abdominal sonography. It's just a binary decision with this examination. You have the decision: is there free, or was there free fluid in the abdomen or not? So it is yes or no, and not perhaps a little and so on, because you have to make a decision afterwards. You have to decide: do you make an emergency laparotomy, or do you make perhaps a full body CT scan? So, and it was initially done for blunt abdominal trauma, and it replaced, I think in some places of the world, they still do this DPL, this diagnostic peritoneal lavage, but it's more a historic examination. So eFast or FAST replaced this invasive diagnostic tool completely. So the importance of detecting free intra-abdominal fluid is the point. You have to decide: do you go to the operating theater and make an emergency laparotomy, or should you go to a whole body CT scan? So that's the decision you have to make in the emergency room. And if you have a look on this slide, you see there's an evolution of FAST, and this evolution is called eFast. So if you have a look on this decision tree, we had, so I think this is the laser pointer, yeah. We have here the hemodynamic question. So is the patient stable or is it unstable? In stable patients, and you find free fluid, perhaps you can go to a further CT scan, or you just say, okay, the patient is stable. Perhaps this injury could be treated conservatively. But if you have an unstable patient and you have a positive eFast finding concerning the free intra-abdominal fluid, you should immediately go for an laparotomy. And so this is the decision you have to make with the FAST in the emergency room. So there is an evolution. FAST became eFast. eFast stands for Extended Focused Assessment. And extended means we included the thorax. So we decided there are 2 or now 4 reversible causes for traumatic cardiac arrest, and 2 of them are in the thorax. So we have the pericardial tamponade, and we have a tension pneumothorax. And with eFast, you're absolutely safe to detect an pneumothorax. You cannot say it's a tension pneumothorax, but you can detect a pneumothorax. You can say, okay, if the patient is unstable and so on, you will go for a drainage or thoracostomy very quick. So it's the thoracic extension of FAST. You can give a good overview of the condition of the circulatory system. You're looking for pericardial effusions, and you can detect pneumothorax and pleural effusions. So eFast POCUS, where is the point of care? It's the next, okay. So that's the next question. Where can you use the eFast tool? of course, in the emergency room setting for observational purposes and in preclinical settings, so-called pre-hospital ultrasound, PHUS. And we had one big incident in Graz. This was the rampage in 2015, I think, yeah, where we had a lot of casualties, a lot of patients with blunt trauma, and the eFast was used in a preclinical setting to make a good triage and to find the appropriate hospital for the right patient. So, so this was done in a pre-hospital setting. So if you have this, this algorithm for preclinical trauma care, you have 3 points where you can use the eFast. So the first is the catastrophic hemorrhage, to find massive bleeding in the abdominal or thoracic cavity. The second time point is here for breathing. You can rule out B problems, for example, tension pneumothorax, or problems with the pericardium and the tamponade, as well as here for C, eFast, it's the same, tension pneumothorax, you have a C problem as well, and pericardial tamponade. So, and it's a good tool as well as in a resuscitation situation, because if you think about making an open cardiac resuscitation on the scene, on the field, and you know the best outcome is with patients with their pericardial tamponade, you can find your perfect cohort for doing this procedure. So 3 or 4 reversible causes for traumatic cardiac arrest can be treated preclinically. It's the pericardial tamponade, the tension pneumothorax, hypoxic. Hypovolemic is perhaps a problem because we still have no good answer for really a hypovolemic cardiac arrest, but all other 3 you can find and you can deal with. But you should not lose a lot of time when you do the eFast, so eFast has to be done very quickly. That's the main problem, because we know time is life, time is brain, everything. And you should not lose a lot of time. So eFast perhaps could be done when you're waiting for the helicopter, perhaps during the flight or during the transport with the ambulance car. So there are a lot of good ideas to say when do you have the best point to make this, this examination. So some basics for the eFast. When you use the eFast, I mean, we have now much modern, very small sonography tools. It's like an iPad or anything from the size. But usually you start with a curved linear array transducer, where you can use a wide-banded. Okay, this is it. Wide-banded array transducer. It depends on the device you use, and you should start with the abdominal preset. So this is the start configuration. And we all know now the indicator probe is pointed upwards or to the right. So what are the basics for the eFast scan? The patient should be in supine position. This is the normal position. You start preclinically or in the emergency room setting. There are some ideas about Trendelenburg position. But now we use the supine position, that's the default position. And one very important thing, and we had some radiologists, they think they cannot really perform the eFast when there's a pelvic binder or splint. But that's one big point. Do not remove the pelvic splint or binder. You can go a little bit downwards to the knees, but you should really compress the pelvic, the pelvis, otherwise you lose a lot of blood, and this is not really a good idea in very unstable patients. So the next thing is do not remove the collar, but I think we should not talk about this. So if you if you're looking for free fluid, how can you find free fluid? Usually you are looking for hypoanechoic areas. Fluid perhaps maybe blood, but we are not very safe, especially in very fresh bleedings, if it's blood, or is it perhaps urine or anything else you can find in abdomen. So there are some pitfalls, but usually there is one rule. if you have such an hypo or anechoic area in a round shape, it's normally in a hollow organ. So don't say we had some pitfalls here, and I'll show you afterwards some of the problems we had with the sonography initially. But if you find this structure, it's never free fluid. For free fluid, free fluid, you are always searching here in this area. It's really sharp angles, and it's filling the rooms between the hollow organs. So this is one very important point, not in a round shape. What are you not able to find with eFast? That's also a very important question, because the patient may be unstable and maybe can have a hemorrhage, a big hemorrhage, but you cannot really detect with eFast. It's the big area of the extraperitoneal hemorrhages, for example, in pelvis or pelvic injuries, where you can find the blood in the retroperitoneal space, and you're not really able to detect this with eFast. There is now a modification for some specialists. It's called ReFast, a very special protocol to find retroperitoneal hemorrhages, but that's not normal eFast, and it's not for preclinical use or standard use. So perhaps sometimes you cannot find subcapsular lacerations or hemorrhages of solid organs, and that's not your mission with eFast. You should find free fluid, and you should not make a solid organ scan. In some cases, you can say, okay, perhaps this could be a laceration of the spleen or anything, but your decision you have to make is yes or no. Is there free intra-abdominal fluid? And if the patient is unstable, do we go right or directly to the operating theater? The next problem is clotted blood. Sometimes you can have problems to detect clotted blood because you don't have this typical hypoechoic area. It's more solid. Okay, let's start with the first view. It's the subxifoidal view. There are different approaches, but we usually start with this approach because if you have a pericardial tamponade, the patient perhaps will die within the next 1-2 minutes. So we start with the more serious injuries. You put the ultrasound gale in the subxiphoid space with the probe. You start with the so-called subxiphoidal window. So you go direct through the liver. You use the liver for your scan of the pericardium, and this is the view you routinely have here. This is the procedure. So you flatten the probe, and sometimes if you have very obese patients, it could be hard to detect the pericardial structures. But in these cases, perhaps you can go also between the ribs, like you do it for standard cardiac echo. But this would be nicely if you detect here. And perhaps you have a look on the function, on the ejection fraction. But the main thing here is to find here liquid between the liver and the heart, so in the pericardial sac. And if you find here a liquid, and if it's compressing the atrium, then it's a hemodynamical significant compression, and this could lead to a cardiac arrest within minutes. So this is the first thing you find here, fluid or not. That's number one. Next thing is you examine the cardiac functions. Another thing is if you really have a cardiac arrest, you can very good see cardiac fibrillation in echocardiography, or if you in the subxifoidal view. And if you have no ECG at this point, you can go on with the pedals and try to restart the heart with a shock. So pericardial ventricular fibrillation can also be detected. Unfortunately, I do not have a picture or a video of cardiac fibrillation, but it's very impressive. So you're looking for the pericardial effusion. We're looking for atrial compression, and the problems, some cases, is the stomach bubble you can have in this area, and in some cases you won't find really was only some small parts of the heart, and you don't have this 4-chamber view. So this is a problem sometimes you can use to go more from the right side and try to move the stomach a little bit to the left. There are some tricks for this, yeah. The next view is the sagittal view on the right side with the indicator pointing upwards. And you have a good look on the IVC. You see if there's a problem with volume, if is the IVC collapsing during inspiration, expiration, is it the total collapsing? And you have a look on the liver here, and perhaps you will see first signs of free fluid around the liver in this view. But the first thing is to find the IVC. You follow the IVC to the right atrium. As you can see here on the video a little bit, this is the right atrium. You go to the right through the diaphragm, and perhaps you can see here as well compression or fluid around the right atrium in some cases. But this is the IVC view. So here, IVC view, you examine respiratory motion, collapse of IVC. If it's flat, it's a sign of hypovolemia, and you're looking for the confluence and the right atrium. So the third view is the Morrison view. So now we change to the abdominal cavity, and you start here on the right side, indicator pointing upwards, to use or to examine the Morrison pouch or hepatorenal space. You have here the liver, you have here vertebra, you have the kidney, you are looking on here this line between kidney and liver, and if you have no black stripe between both organs, you don't have free fluid here in this Morrison pouch. Here's the diaphragm. You routinely will find mirroring artifacts, because if you have the diaphragm and above the diaphragm you have a normal lung, you will have this mirroring artifact, and if you have fluid, you will find here such hypoechic sharp angle areas indicating pleural effusion. So coronal view in mid-axillary line, and you move cephalad a little bit to the costophrenic recess to find fluid here. So we examine hepatorenal space for free fluid. We're looking for the right costophrenic recess, and mirroring means no fluid. And you can here see good the lung sliding here anteriorly, and this is indicating there's no pneumothorax on this side. You can have a look on the inferior kidney pole, and the problems are, especially in young patients, the ribs. The ribs are blocking your scan, so you have to go upwards. You have to wait for breathing action, or you have perhaps to turn a little bit or rotate the probe to find a good window between the ribs, so that you don't have a blocked view. The next view is the collar view. It's view number 4. It's the left upper quadrant, the collar pouch or splenorenal space on the left side. You have here the left kidney, diaphragm here, and between diaphragm and kidney you have the spleen. And like on the right side, you are looking for black stripes between both solid organs, and it's also coronal view with the indicator pointing upwards. It's also mid or posterior axilline view, and you move, like on the right side, upwards to the left costophrenic recess, and you're looking there for free fluid, and you have a look on the lung sliding to find any pneumothorax. So splenorenal space, both interfaces, kidney, diaphragm, left costophrenic recess, looking for pleural effusions and lung sliding, and you're looking for fluid around spleen. Don't make a solid organ diagnostic. You're not really able with a normal eFast to detect such lacerations, subcapsular lacerations. I mean, there's some studies and some specialists performing an ultrasound enhanced echovist enhanced, contrast agent enhanced sonography of the abdomen, and in this contrast agent enhanced examinations, you can find perhaps solid organ injuries, but there's no place now in the algorithm. So if eFast is negative and we don't go to the operating theater, the next step is a multi-slice whole body CT scan. The same problems on the left side with the ribs. Perhaps you have here also to move more posterior and to rotate the probe in an oblique direction, and perhaps you have waited for a ventilation window, the spleen and the left kidney going more crowded, and you perhaps won't find the inferior pole. So the next important view is the view number 5, looking for free abdominal fluid in the retrovectinal space, but I mean especially behind the bladder. You place the probe just right above the pubic symphysis and the pelvic floor, and you have this view of the bladder, and it depends if you have male or female, if you have rectum, prostate, and here you find the free fluid, or you have the uterus. But it's the same for both gender. You have a median secondary view. Here you examine free fluid around the bladder, and if you find free fluid, it depends how much free fluid you find, and then it depends if you have a male or female patient, because if you have female patients, it can be normal, a little amount in fertile female patients, a little amount of free fluid here in the recto-uterine pouch, but this amount of free fluid, it's absolutely not normal, and you find the fluid is sharp angles around here, is filling the space between the free bowel, and you can see it in this view. Very good. It's a very sensitive view for free fluid. Sometimes, or normally, you can hear a little acoustic enhancement behind this bladder. That's normal with ultrasound, and perhaps if you have really a very good acoustic enhancement, perhaps you can miss here sometimes a little amount of free fluid. Problem, you have to go down with your gain, or to make or you to change your settings concerning depth and on enhancement, and you can find here free fluid. So this is a problem sometimes if the bladder is really completely full. So you're looking on the roof of the bladder here, and you're looking here for free fluid. So the next step is to turn the probe counterclockwise and to have a transversal view of the bladder and the pelvic floor, and you see here the change from secondary to transversal view, and you're looking here for free fluid, and it should be then positioned in this area and on both sides. Here's the same, you have this acoustic enhancement, so perhaps you think this could be free fluid, but you have to think this is enhancement, this is normal, so this is no free fluid, and it depends on the filling of the bladder. So this is the next thing, acoustic enhancement behind the bladder in transversal view. Usually you pan a little bit superiorly and inferiorly to identify the prostate and the uterus, and normally the bladder is square rhomboid shaped, so this is of course no free fluid. We have a round organ with a hypoechoic area, so this is of course the bladder, and here on both sides of the bladder and posterior to the bladder we are searching for free fluid, so this would be in an ideal situation the free fluid you can find in such patients. The same problem of overgaining the whole picture, and the problem of late pregnancy where you have absolutely other anatomic structures, and you see the baby but nothing else here in this area. So the last views are views 7 and 8. So we started with the thorax, we started with pericardial tamponade. We have this 4-chamber subxiphoidal view. We have the IVC view. We had the right and the left pouch, collar Morrison pouch we had now the transversal and sagittal view of the roof, the pelvic roof, the bladder scan, and we finished the whole thing with the sonography of the pleura. And this is a very simple method. If you're a little bit experienced, you see here this sliding of the lung. Okay, everything works. If you're not sure, you can take the M mode. You start with the M mode, and if you have this so-called sandy beach wave pattern, you know, okay, there is normal lung sliding on both sides, or there's a pathological picture on one side. You have here these ribs. Of course, you have to move your line here between the ribs. On the ribs, you won't find any movement. So this is a problem, of course. The surgical view indicator upside, M mode for pleural. And if you have really this picture, so-called barcode sign, if you have a static picture and there's no movement, no waves, no sandy beach, it's a sign for its indicator you have found a pneumothorax. So we examine two ribs. Between the two ribs, we're looking for the pleural sliding, and we search for the sandy beach and waves pattern. And if you have really this reverberation sign or barcode sign, and the patient is unstable, next step is you will insert a tube in the thorax. So eFast is now done. We have an idea of the cardiac function, of the fluid state. We have ruled out pericardial effusions and tamponade. We have ruled out free fluid in Morrison or collar. And we have ruled out perhaps pleural effusions, a kind of hemothorax. And we have ruled out free fluid on pelvic floor, and of course a pneumothorax. So with this eFast, from the initial diagnostic tool, just to say yes or no concerning free fluid intra-abdominal, it has expanded to answer all these questions. It's a tool you can use within 1 or 2 minutes if you're really familiar with this examination, and it's a very powerful tool. But you have to think about this. If you make, or if you give it a yes or no after this examination, it has consequences, because you bypass the CT scan and you go directly to the operating theater. And if you perhaps made a wrong decision, in some cases, we had some cases, we are too late for our things. If you don't have a whole body CT scan, you won't find dissections of the aorta. You won't find big pelvic injuries with a massive retroperitoneal pegging, perhaps, that would be necessary. So be careful with this decision, yes or no, but it's definitely a very powerful tool. So what are the effects on eFast concerning, for example, ATLS or BHTLS protocols, as well as TCCC protocols for military environment? So let's start. This won't work. Okay. The first thing is, with eFast, we can find a perfect indication for resuscitative thoracotomy, preclinically or in emergency room. So if we don't have pericardial tamponade, if we don't have fluid in the thorax, perhaps a thoracotomy in the emergency room will fail. So this is a perfect tool to indicate this resuscitative emergency thoracotomy. What is the effect on, for example, PHTLS? We all know this algorithm. If patient has beep problems, has a respiratory rate of more than 30, has painkillers, oxygen, and is deteriorating, still you have to put in a chest tube. Or in military environment, you make just the decompression, you use the decompression wheel. And that's a problem, because in middle of Europe, we don't have this great amount of penetrating thoracic trauma. Most trauma in Europe are blunt trauma, and flail chest and problems with ventilations are number one concerning intubation rate. So for example, in Austria, we can use this tool to avoid thoracostomies without indication. So with flail chest and so on, they need a ventilation, they need a tube and not a decompression. If you start with inserting a normal tube and ventilate the patient, perhaps afterwards there can be a need for further things like thoracostomies to avoid afterwards tension pneumothorax when you ventilate the patient. But don't start with with chest tubes and decompression of a perhaps tension pneumothorax if you don't find any tension pneumothorax in eFast. So this is quite a good tool to avoid decompressions of the thorax. Geht's nicht? So the next thing is you can use this. Okay. So next is you can use your eFast device to assist for special treatment options we have now. For example, the rebore balloon, as I already told you, insert this balloon and you include the aorta, and you can use this your device to find the population of the femoral artery. I mean, you can do it in a blind way, of course, but if you have your ultrasound with you, just put on the probe and you will find direct access to the femoral artery to insert the catheter for the sheath for the rebore balloon. So these are the indications for pre-hospital use. Yeah, let me show you some cases and pitfalls as well. There's one pitfall, it's the so-called look-alike pitfall, when you think you find some pathology and it is not really a problem or injury. We had a 34-year-old male failed suicide by jumping in front of a moving train. He missed the train and the train laterally hit him, not frontally. And patient arrived in emergency room with blood pressure of 192/95 and a heart rate of 113. So there was no really hemodynamical problem, and the main problem was the traumatic brain injury with the so-called Cushing effect, high pressure. But a patient had in a physical examination a flail chest and a complete cauda equina syndrome. So there was no movement of legs, no motor reaction. Yeah, this is one picture here. That was view number 3, this is a scan of the bladder. Is there anything you will find, perhaps? First view, is it normal, or is there any pathology here? Normal, hands up. Okay. So next view. I mean, it's a static picture, so you can of course say it's a dynamic examination. So don't show me static pictures; doesn't make sense. Okay. But the next picture. This is the bladder view, the sagittal bladder view, number 5. Here's the bladder. You can have a look on the roof of the bladder. This is normal. It's a male patient. Do you see free fluid on the picture? Hands up, who is for free fluid? Little amount. Okay, no one. Good. The next picture. This is a transversal view of the bladder. You agree? This is done by a radiologist, so a specialist. Has saved this picture in our Medox system, so it is safe for 100 years. What about this? This is free fluid. I mean, first of all, I'm not really able to say what view is it. I mean, you don't see any landmarks here, but is this typically free fluid? So what about free fluid? Yes, you're right. You find here perhaps sharp edges. We have a look on here. This is the so-called lookalike pitfall. But it also could be that there's a big hollow organ, and in this hollow organ you find different kinds of echoic structures. This is perhaps hypoechoic, this is more echoic. But who's for free fluid here? Is it free fluid? So you have to make a decision. You see this picture, I know perhaps it's not a perfect examination, but you see this picture and surgeon asks, should we go to the operating theater? I mean, I say no, the patient has 192 blood pressure, so stop, yeah. I mean, we do a CT scan. But this is definitely not a picture of free intra-abdominal fluid. This is a pitfall here. This was wrong, definitely. And this was interpreted by the radiologists of this is free intra-abdominal fluid, and the whole thing started. What was wrong? This was the stomach, and the patient, and this is mineral water with gas, and you see here the gas in the stomach. So this is a typical pitfall. If the stomach is full, very full, yeah, you find in the area of the whole abdomen, and you see here this is the border of the stomach, and this is all fluid inside the stomach and not intra-abdominal free fluid. So let me summarize a little bit the examination now. We start with supine position. We use a curved linear probe. We are not allowed to touch pelvic splints or collars. They should stay. Perhaps you go a little bit more, you put the collar splint, you pull it in a more inferior position. You start with an abdominal preset. You start in the subxiphital space, and you make your standard views. So this was view number 1. This is the subxiphital view. You are looking here for, of course, cardiac function a little bit, but here for free fluid around the heart and between heart and liver. You proceed to the IVC view, have a look on the fluid state. Is it collapsing? Is it not collapsing? Perhaps you can move a little bit upwards to the right atrium and see the influence of the right atrium. Then you go to the right side. You go to the Morrison, and you see here you're looking for free fluid between liver and kidney. You have a look on the diaphragm. Do you have, like here, this mirroring artifact? You don't have free fluid in the thoracic cavity, and you're looking here for free fluid, of course. You're going to the left side, view number 4, the same between spleen and kidney. You're looking for free fluid around the spleen, and you're looking here for the lung sliding and perhaps for pleural effusions. You go on, you proceed with the bladder scan, transversal sagittal view. You start, you're looking here on the transversal sagittal view for free fluid, Douglas or rectoprostatic pouch. You turn it around and you have the transversal view, and you're looking for free fluid on both sides of the bladder, a little rotating the probe upwards and downwards. And you go on with the thorax scan between 2 ribs. You're looking for the sliding of the lungs, and if you're not sure, you take the M mode and look for a barcode sign or the normal sandy beach and wave pattern. So, thank you very much. We'll stop here now.
Thank you very much for your for this first and very exciting lecture. Are there some questions from the audience? Yeah.
Hello. You mentioned before before that the possibility that there is a possibility to miss aortic structure defects or wall defects such as aortic dissection. And once you have a patient and you suspect after a trauma, for example, that a patient has an aortic dissection, do you still try to see this while doing the eFast, or do you just do the frontal bolus protocol, or do you try to pan a little bit to the left side while you do the inferior vena cava section?
Yeah, no, this is definitely no indication for an eFast diagnosis. You start with your eFast protocol. You make this. I mean, if eFast works and is very powerful, is if you're fast. So eFast fast, yeah. You have to be fast, and you don't have a good sensitivity for wall lacerations of the aorta. You need a really contrast agent. So Polytrauma protocol. It's a biphasic special protocol where you can see really good structures in the thorax. And the same problem is with the mediastinum. You cannot find anything in the mediastinum with the sonography. I mean, in the posterior part. And for example, if you have in the CT scan fractures of high thoracic vertebrae, you are looking for aortic dissection because the force goes in most cases in a line through the body. And if you have a sternal fracture and you have rib fractures and you have vertebral fractures here in this region, you really have to look for aortic dissections. Even in CT scans, sometimes you miss them on the first day and you perhaps will get problems. So definitely this gold standard is Polytrauma whole body CT scan. So this is we should not try to find things with eFast or with the sonography which is not really perfect for this indication. So
thank you very much. We now. Oh, there was one more question. Perfect. Okay.
Hello. Are you always supposed to do it in the same way, or are you changing it up? In which, when you think you have a like.
I mean, you mean the
first view and second view.
Okay, yeah. Well, this is a little bit theoretical. You're absolutely right, because I mean I try to teach it in this from 1 to 8, but of course sometimes we have radiologists performing the eFast scan, sometimes anesthetists, sometimes surgeons do the eFast scan, and perhaps everyone has a little bit his own way to do it, but sometimes you have to look afterwards. Have you saved all views, both pleural views, subxival views? Some of my colleagues do not make the IVC view. I find it's helpful, the IVC view, because to have a look about the fluid state. But routinely, you should at least you should have a system for your own to perform it.
Okay, thank you.
Some more questions? No. Okay. Then now we want to express our gratitude with some little presents from regional products from Austria.
Thank you very much. Thank you very much. Thank you.
Yeah, genau.
It's a pleasure, even after night shift. Perhaps next year we will see.
Perfect. Thank you.
Thank you.
Okay, so we'll now have a short break of 15 minutes. It's now 5 to 10, so we'll meet again 10 minutes after 10. Okay, so 10:10. See you later.